Hello, everyone. I'm Luis Ortega from Air Intervention, and today I have the pleasure to host the team in the Netherlands. We have Dr. Jonathan Loss and Professor Robert Jan van Geus from the Radboud University Medical Center in the Netherlands. They have published recently in the last issue of Air Intervention a very interesting trial entitled the FITTER trial, which is looking at non-culprit coronary lesions and the effect of PCSK9 inhibition on them. Um, we would like to invite all the readers to take a look to the article online. You can download it. It's truly an excellent study in which we will have a lot of fun discussing with the primary investigators. Uh, Jonathan, Robert, thank you for your time. Thank you for having us. And I will kindly ask you if you can start digesting a little bit the study for us in terms of, which was the rationale for running this study, the hypothesis that you have in advance, the methods that you follow, the main results.
Yeah, all right. Thank you, Louis. Thanks for the introduction. So I'll give a brief overview of the study design. It was actually based on the Yellow trial published back in 2013, which they saw when you start a high intensity statin therapy compared to a moderate statin therapy, that they found a reduction in LCBI, which was accompanied with a non-significant increase in FFR, and that this therapy only lasted for 8 weeks. So we hypothesized that if we extend the treatment period for a few weeks longer and add a PCSK9 inhibitor on top of this, we hypothesized that we could maybe even improve FFR significantly, which would affect in ACS patients the non-culprit lesions and the decision of whether to perform a PCI on this. So we designed a randomized trial in which we included 150 patients, and we randomized them in a 1-to-1 ratio to a PCSK9 inhibitor in addition to a high intensity statin therapy compared to the high intensity statin therapy as background therapy. And these were all ACS patients with a relevant non-culprit lesion. So a successful PCI had to be performed, and the non-culprit lesion had to have an FFR of 0.67 to 0.85. So only relevant lesions which a non-culprit PCI was considered. And we treated them for 12 weeks, and we performed a repeat angiography after 12 weeks. And together with the FFR, we did a IVUS-NIRS imaging in a subgroup of patients, about 90. And our main endpoints were the difference in change in FFR, the difference in change in max LCBI as lipid content value, and plaque volume parameters derived by IVUS. So after 12 weeks, we looked at the overall change, because in both groups, lipid lowering therapy was increased, and the difference in change. Well, the PCSK9 inhibitor group showed a significant decrease also compared to the placebo group in LDL-C already achieved after 1 week, which was maintained for the weeks after. So the LDL-C decreased significantly more in the PCSK9 inhibitor group. But after 12 weeks, we saw an overall decrease in max LCBI, so decrease in lipid burden, but there was no decrease in FFR in either group. So the mean at baseline was 0.78, and at follow-up it stayed the same. And also in the short time period, there was no significant change in plaque volume parameters, only a trend towards a decrease in total atheroma volume, but no significant difference between the two treatment groups. So if you put these into perspective to the other trials, looking at imaging outcome parameters, we saw a improvement in plaque morphology, as we saw a decrease in max LCBI, but no significant improvement in plaque volume and neither in intercoronary physiology measured by FFR.
Okay, it's very interesting. I really commend your whole team of investigators for this study. And the methods of these studies are very strong, very clear, randomized, blind, placebo control, truly multimodal imaging with FFR assessment first, and then IBUS, NIRS. So I really think that the new evidence that you're putting on the literature is very compelling. And I want to enter now a more directed question and answers with you, okay, to try to highlight for the audience that listening us live on X and all the social media channels from our intervention, a couple of points that I think they are interesting to discuss. And my first question will be, um, how would you compare your trial? Because this is not, there is, I won't say a long list, but there is already a couple of trials analyzing PCSK9 effect on intracoronary imaging on plaque morphology. How your study compared to these prior studies? For example, Pacman, Geuns, and the same yellow trial that you mentioned already. So which are the similarities and the key difference that your trial have with these prior studies?
Yes, a great question. This study was designed, I think, in 2018, 2019. So the Pacman and the Geuns were not published yet, but they were published in the meantime. Two very beautiful trials in which they looked at the similar patient population. So they included ACS patients with a non-significant stenosis between 20 and 50%. In Geuns and Pacman, and they randomized them also to a PCSK9 inhibitor in addition to statin therapy or to statin therapy alone, and they looked at plaque morphology and plaque volume mainly, and they assessed the differences after 1 year, and they found a significant decrease in plaque volume and an improvement in plaque morphology in the treatment arms compared to the control arms. But the main difference is the treatment time, is that they looked at 12 months, and we looked at 12 weeks, and we included FFR to see whether we could improve that in a short period in more significant lesions, which was confirmed by an FFR below 0.85.
Okay. I think that's very, very, very interesting because we need to fit your study within the prior evidence, and I think that you have done a wonderful analysis on that. And then for me it's kind of interesting, eye-catching, that Pacman we know that was strongly positive, a lot of plaque reduction. Why do you think that your study results are different from Pacman in some way, or prior evidence, and not necessarily just Pacman? Do you think there can be a degree of underpower of the sample? Do you think the time of a study really make a difference? And I know you have some thoughts about, the more you are exposed to these medications, the more effect probably you will see, as in the main PCSK9 trials.
Yeah, I think that the main reason that there was no between group difference is the time. I think 12 weeks is too short to see a between group difference. Also, the number of patients on statin therapy at baseline in our patient population was low. So also in the placebo group, lipid lowering therapy was mostly intensified in most patients. So some degree of improvement was expected in that patient group as well. But in both groups, we saw a similar improvement. And I think it has to be with the duration of therapy, which the Pacman has, they showed us that the continued therapy has beneficial effects compared to only the statin therapy. I think that's the main reason.
Yeah, we created some hypothesis on saying, is there a kind of maximum lipid washout? So if you go to 1.4 millimoles or 0.7 millimoles, it doesn't matter in the first 12 weeks. In that period, both arms showed an important reduction in LCBI. If you continue for 12 months on such a low therapy, then the final effect from PCSK9 might be higher than only statins, as we have done in the past. So that doesn't mean that we don't believe the other trials. I think that still all can fit together in this kind of concept. The ambition to treat something in 12 weeks is that we know as clinical doctors that if we see a bystander lesion, we say, okay, we can potentially stage that. We can do it acutely, or we can either stage it. And if we can stabilize it, and that's also Beckman was showing, the cap is getting thicker, the LCBI is getting lower. So the risk of these lesions, even if the function, the FFR is not changing, the risk of future events might already reduce if we initiate this very first period. And we still see an option that if we have a clinical endpoint, of course, none of these patients were stented in between in the 12 weeks. So they were all stable, no infarctions. And even at the end, only 30% of the patients did get a stent in the end by the operators. There was an operator decision at the end of the study. So this is a kind of reduction of 70% of your stenting of your bystander lesions with a first pharmacological approach versus going for stenting everything we see. We know cardiologists, interventional cardiologists say, eyeballing anything which looks like significant, I will stent it anyhow. And I think we should try to avoid that.
I fully agree with this, with your comments, and I think we, in the last decade, we have understood that these new medications has done a real difference, the management of patients, Now we have wonderful drugs for lipid lowering therapies, for diabetes, obesity, even heart failure, which is not the topic now, but I think that we all have to adapt to that reality that medical management has improved significantly. And I also think that the fact of time is very important. In the main 4-year study, even the 4 investigators, they make a strong point that their primary endpoint was probably too short, and that when they did the open label extension study, they actually look at the reduced number of recurrent events and was drastically reduced with the PCSK9 inhibition. So I really think the time part is an important variable in your study, and I think it is a valuable concept of stabilization also, which I like, and I think is a good message also for all the audience and the readers. I would like make just a last single question for both of you, and it's about future research. I always like to ask what you are thinking in doing, if it's just possible to be disclosed, of course, regarding FITTER, any other potentially related project within this study. So please let us know if you are looking into something like that.
Yeah, well, just as Robert Jan just mentioned, it would be interesting to look at more severe significant stenosis as we included in the FITTER, and see what extended treatment would do on these lesions. That could be a point of future research.
Yeah, first we will see an analysis on what we call the lesion-based. Also in the Beckman, you have multiple lesions in these patients, multiple high-risk lesions, etc. These data are under review and hopefully will be a follow-up paper soon. The clinical impact, I think, has still a potential to design a clinical trial with staged PCI versus stenting everything, or stabilize the patients and then only stent patients which are at 12 weeks follow-up still at a high risk or clinical relevant. Just put that into perspective. We just did our modern study, a TCT presentation, you should have seen that, where we also waited 6 weeks up to the MRI, and that period was pretty safe. And the MRI saved also 60% of additional PCIs. And we can optimize medical therapy even compared to iModern. So should be kind of iModern 2 and then PCSK9 in between.
I fully agree. Maybe a couple of colleagues will not be happy with the reduction of the volumes, but I think it's best for patients. Less metal is better, and you know the medications are really making a difference. It has been a wonderful discussion with all of you, and I would really like to congratulate for this excellent study, very well designed, executed, very clear results. I want to also mention to the audience and to the readers that we have several PCSK9 studies published in our intervention. We have FITTER, we have the from McMaster Group. Also, we have use of PCSK9 after STEMI, and even we have two sub studies of Pacman in published in our journal. The one about the platelet reactivity, and the one about volume of plaque reduction. With there was a secondary analysis. So a lot of PCSK9 and medical management also in an interventional journal, but I think it is we should adapt to it because it's the reality and the future. No? Thank you, Jonathan and Robert, for this wonderful discussion. Congratulations to all the team in the Netherlands.
Thank you for having us.
Okay, thank you.